Exactly. This is a study that we initiated with colleagues from the Lyon University Hospital, which is my former institution. So we looked back at the records of NGS and molecular genotyping of EGFR over a period of almost 10 years, and we were able to identify patients who had an uncommon EGFR mutation, meaning a mutation that is different than L858R or exon 19, which are the standard activating mutation. We also excluded patients with a mutation for which we know that there is no efficacy of tyrosine kinase inhibitors, such as exon 20 insertion or de novo T790M. At the end, we had a total number of 95 patients with uncommon mutation, including 58 patients who were treated for advanced disease with any kind of first-line treatment.
What was the frequency of these mutations overall?
So it was about 11% of all EGFR mutations, something like less than 1% of the total number of patients who were tested for mutations.
Have any of these EGFR mutations been linked to other diseases or any other etiology?
No, it was only patients with non-small cell lung cancer. We were not able to identify any clinical or imaging characteristics associated with a higher risk of rare versus frequent EGFR mutations.
And then in terms of risk of progression, do any of these have any use possibly for predicting someone's response? You mentioned to therapy.
So the key point was first the description of those rare mutations and the incidence of those rare mutations. And the first finding of the study is that in almost 30% of those patients with a rare EGFR mutation, this is a combination of mutation, either rare mutation, at least 2 or 3 rare mutations, but also combination of rare mutations with frequent mutation, and mostly L858R. So it was unexpected, kind of, because those rare mutations may be observed as single mutation, but in 30% of the patient in association with another mutation.
And you mentioned the impact on tyrosine kinase inhibitory therapy.
So this was one of the key questions, and looking at the survival of patients, we have a tendency toward a better efficacy, a better survival in patients treated with chemotherapy upfront in the first line setting, as compared to patients who receive tyrosine kinase inhibitors with a median overall survival of 27 months versus 15 months with TKIs. Obviously there is some kind of heterogeneity in the efficacy of TKIs depending on the type of mutations, and also this story of single versus combined mutation. Clearly patients who had a combined mutation did better with TKIs as compared to patients without those combined mutations with a single rare mutation. Given the low numbers, ultimately we are not able to compare chemo versus TKIs for each group of rare mutations, but there is probably some heterogeneity here, and we need an additional follow-up for those patients.
Speaking of follow-up, what are the plans for the next steps with this research?
So the next steps are to continue the follow-up of the alive patients. We have still patients who have a treatment that is ongoing. We need to analyze probably in depth the therapeutic sequences, meaning after beyond first line, what treatment was delivered to those patients, what is the efficacy of immunotherapy, because this will be at some point an option for those patients. So we have many additional data to collect through an extended follow-up of those patients.
Okay. Well, that covers my questions. Is there anything else that you would like to talk about? Anything else to add?
No, what I believe is that now we have, when we did this study with available TKIs, and we know that third generation TKIs such as osimertinib and other third generation TKIs that were discussed yesterday during the poster discussion session are coming and into the market. And probably one recommendation would be to include those rare mutations in at least in the early phase trial cohorts to identify whether there is a signal specific for those new inhibitors for patients with a rare EGFR mutation.